Judith. It's an old friend. Lovely to see you too, Judith. I hope you're doing well. Marjorie's joined us. I wonder where all these wonderful people are from. Oh, here we are. From Port Macquarie, and it's sunny. Margaret, thanks for sharing that with us. Way because the numbers are looking quite well. So we might start the recording, Karen. I think that's happening, isn't it? All right. Well, formally, I welcome you all to this webinar on a very, very sunny day, wherever you are. I'm actually in Kiama, as many of you know. That's where I've moved to, and it's paradise out there. So after I leave you this morning, I might put my toes in the water, but I might not. But it's always lovely to look at the ocean. It's a very, very healthy thing. So people who don't know me, my name is Joan Hughes, and I'm the President of Council on the Aged in New South Wales. So welcome to today's webinar. It's one of those topics that's sometimes difficult for people to start the conversation, but that's the aim of our webinar today, is to have conversations and look at what supports are out there for people who are not just at their end of the life, but want to think about end of life care options, how they prepare themselves, and very importantly, how they prepare their friends and family to make sure that the end of life experience is one of quality and choice. So aren't we lucky today to have three experts in this field of talking about death and dying? The first person I'd like to introduce is Stephen, and Stephen's a board member of Council on the Aged in New South Wales and also a GP, and he'll share with you the passions of his area around GPing and talking to people about this very important issue. We also have Megan, and Megan is acting CEO of Palliative Care New South Wales. Wave to everyone, Megan. And we also have Melissa, and Melissa is the CEO of the Violet Initiative, and you'll hear a lot more about that very soon. So, look, I thank three of them sincerely from COTA New South Wales to be able to help us through talking around this very important topic. So, as I said, the focus of today is about having a conversation about what supports exist for end-of-life care and how we prepare ourselves, family and friends, to make sure it's one of quality and choice. So those of you who have joined us before, we encourage you to participate, in the way that you can do that is to ask questions through the chat or the Q&A function at the bottom. And Stephen will be facilitating this webinar, so he'll be able to have a look and see what might be some of the trends or themes that are coming through in that, in that part of your screen, and Megan and Melissa and Stephen will be able to then answer some of your questions. Importantly, when you do post a question, can you just make sure that it's fairly short? We're interested, of course, in all of what you've got to say and share with us, but just try and keep the questions fairly short so that we can look at them. Before I start, as I always do with webinars and meetings, I'd like to acknowledge the traditional custodians of the land we are all on this morning. I acknowledge their connections to land, sea and community, and today I pay great respects to those people who have joined us who might be elders, past, present and emerging, and I pay that respect to First Nations people who are with us today. COTA New South Wales is on, I acknowledge the Gadigal people of the Eora Nation, and that's where our office is in Sydney. So those of you have heard this before, I'm sure, but it's always very important to talk about what Council on the Aging does. And we stand for, people call us COTA New South Wales, but it stands for Council of the Aging, or on the Aging. We are the peak organisation for people over 50 in New South Wales. Our most important work is around policy and advocacy. So we call some people call organisations like COTA New South Wales a peak organisation, but that means that we work with politicians and policymakers, service providers and the media to make sure the views of older people are not only heard, but very importantly are acted on. We also train and support a network of older people to provide independent information and guidance, and we have many programs that we have been doing for a long time and some new ones as well. And you can get all of that information on our website. We're very thrilled to have a group of community speakers. They're volunteers, they're older people who can go and talk to community organisations about anything to do with older people, what older people want to know. So whether it's about navigating that very difficult aged care system, energy issues, which are very important at the moment, the cost of living, a whole range of different topics that they get trained on, and they're all volunteers and very highly regarded by COTA New South Wales. We've started some pop-up peer information hubs, which is exactly as it says, people to get good information about a range of issues for older people. And we're growing a program called Older Men, New Ideas. And of course, that's focusing on older people who are men, and a very important group because we know sometimes older men don't know how to sort of start that conversation about what's happening in their own lives. So, folks, just a little bit of Zoom housekeeping. Everyone except the presenters are on mute, so that's all of you out there. So you actually can't unmute yourself, and that's probably the word, isn't it, that we use so much when we're on all these things. People say, unmute, mute, unmute. But anyway, you have to stay unmute yourself because it's a webinar. It's not a meeting. You can ask questions, as I said, at any time by typing them into that Q&A panel. You can also upvote someone else's question. If they're asking something that you would like to know, we'll be answering those questions, or Megan, Melissa and Stephen will be answering those questions during the panel discussion. And if we don't get to all of them, our apologies, but we try and look at the themes of what those questions are. So please put any comments in there. And we'll be giving you some 1300, 1800 numbers to support you should any of the issues that I talked about this morning bring up for you. It's very important that you talk to people if it brings up difficulties for you. And the last thing is this event is being recorded and it will be available shortly on COTA New South Wales YouTube channel, along with all our other previous webinars where you can find a whole lot of information, the do's and don'ts of downsizing, the issues to do with the yes and the no vote for the referendum coming up. So we choose topics that are important to older people by giving them information. So folks, it's a hard topic, as we said, very, very important topic. Please enjoy all of the information that you're going to get this morning. Make sure you've got a pad and pencil with you, because often there'll be gems that Megan, Melissa and Stephen will share with you, and it's good to jot them down. So I look forward to seeing you at the next webinar, and now I'll hand over to Stephen.
Thank you, Joan, as always. And thank you, Joan, for that excellent introduction, and also for all the work that you do and have done over many years, your passion for COTA New South Wales and COTA Australia. I don't think people ever know how much work someone like yourself puts into being president of an organisation like this. So thank you.
Thanks.
Also, thank you. In that little box that says COTA New South Wales is another wonderful person, Karen Appleby, who, when I with my slide says, I say move the slide, she's the one who's the Wizard of Oz, or the Wizardress of Oz. She's managing it all from behind. So thank you, Karen. So Joan's gone. Presumably I'm here. So I've been a GP for about 50 years, and so I've seen a little bit of life and death, and out of that, if we could put the first slide up. Thank you, Karen. It's led me to wonder whether we're doing this life and death stuff the right way. I've over the years found that all aspects of medicine are becoming more and more medicalized, and I'm passionate about the abilities that communities have, and so my work in this area with COTA New South Wales is to rekindle that knowledge and ability that we have in our communities to look after each other and to look after ourselves. the origin of that word compassionate comes from the idea that we're doing things with people. Care is more something that we do to people, not down on care, but compassion is very much marked by doing things with people. So thank you, Karen. If we just move on to the next slide. Well, I'll give you a little. There we go. So we want to live in a world where every person, every family, and every community knows what to do when someone is dying or grieving. We all know a little bit more what to do around birthing, and we prepare for birth, but we don't prepare for death. 70 to 80% of people want to die at home, but only 20% do. That will double over the next decade or two. And dying is becoming increasingly institutionalized and medicalized. The Australian Institute for Health and Welfare keeps an eye on all these figures, has shown that there's been a 23% increase in the number of palliative care related hospitalizations. And in my conversations with my colleagues, we know that many of these hospitalizations could be avoided by more what we call death literacy. Hospital care is more expensive than community palliative care, and A&E, accident and emergency admissions at end of life, are increasing at an alarming rate. So to try and work with my passion that we have people more able to look after themselves, look after their neighbours, look after their families, I've been working with Groundswell, which is an international leader in death literacy. Our vision is for communities to help us live, grieve and die in line with our values and choices. And I thought I'd devote a large part of this little introduction to the Dying to Know Day that we like to run every year. And this year we had over 150 events nationwide in halls, workplaces, cafes, and our one happened to be in New South Wales Parliament. So next slide, Karen. Thank you. I think I should say here that if any of you find this conversation challenging or upsetting, please remember that the Lifeline number is 131114, and we'll put that in the chat. And also, as Melissa will tell you a little bit later about her organisation, they have a helpline as well, 1-800-VIOLET. So we'll put that up in the chat, because this is all about having a conversation. And if this is found to be a difficult topic, it's important to share that with people. Break the hush about death and dying, as our CEO, Marika Kontelis, said in her opening remarks at Parliament House. We know that connecting people works. There is a formal community connector program that we were told about at the Dying to Know Day, and this will hopefully be part of our strategy here at COTA. We know that the hospital system is too expensive and doesn't deliver efficient services equitably, and the Compassionate Community Connector program provides the evidence. Next slide. Thank you, Karen. So at the Dying to Know Day at Parliament House, Professor Samar Aoun, who is West Australian of the Year, she works in palliative care in Southwest WA, and the the town where she's developed this project, which is mirrored all over the world, but this is the first one that's been launched in Australia, is in Bunbury. And new research shows that innovative models of death and end-of-life care, where community works in partnership with healthcare services, enable better dying outcomes as well as cost savings for the health system. Known as compassionate communities, this approach encourages communities to use its inherent capability to provide practical and emotional support for those who are caring, dying, or grieving within the community. And we'll hear from Megan and Melissa later how their organizations help to bring this to fruition. So next slide, thank you. So Melanie Gould, who's a First Nations person from Sydney North Health Network, stresses that as we discuss various aspects of death and dying, let us do so with sensitivity, reverence, and modesty, recognizing that there is no one-size-fits-all, and that may we cultivate a genuine appreciation for the diversity of cultural practices surrounding this important topic. Thank you, Karen. Remember, when it comes to life, there's no one-size-fits-all. We're a diverse community with different cultures, and we come which are beautifully varied and diverse practices around caring for the dying, end of life, and bereavement. And the more we talk about and share these experiences, the more we can learn from each other about how to do death better. These programs simply work. They benefit the health system, communities, and individuals. This is all about having the conversation. If you want to shorthand it, have the conversation. This is a good rule right through life, in my experience as a GP. If you've got a problem, talk to those around you about it. And the next slide, thank you. So that's me at the meeting. We have much to learn from the knowledge of First Nations people when we make social choices about how we will live, die, and grieve. Healthcare professionals and community members need to share their care and their knowledge. Next slide, thank you. Oh, that's the end. Okay, I think there were more slides, but might come back to them later. Thank you. So, first of all, I'd like to introduce Megan. Megan was introduced to palliative care in New South Wales way back in July 2015 as part of an internship program while completing a Master of Policy and Applied Social Research at Macquarie University, concluding a study on palliative care volunteering in aged care facilities during this time. Since then, Megan has worked as a policy officer for Palliative Care New South Wales, undertaking research into the experiences of volunteers in paediatric palliative care, CAL communities, that's culturally and linguistically diverse communities, and palliative care, and most recently, homelessness and palliative care. And I believe, am I right that you're currently acting CEO of Palliative Care New South Wales? And very nice to hear about paediatric palliative care, because we forget that the young as well as the old do die. So over to you, Nick. Thank you very much.
Thank you, Stephen. I'll just share my screen with everybody. Okay, everyone can see that?
Yes.
Perfect. So, just going to shut that. So thank you, COTA, for the invitation to talk to you today. My name's Megan Asbury, and as Stephen said, I work for Palliative Care New South Wales. And we're the peak body for palliative care in New South Wales. So it means we're a member-based organisation, and we represent healthcare professionals, volunteers, and consumers in palliative care. Our goal is to enable all people in New South Wales, whoever they are, wherever they live, to be able to access equitable, high-quality palliative care. I'd also like to acknowledge that I'm presenting today from the land of the Gadigal people of the Eora Nation, and pay my respects to elders past, present, and future, and recognise their enduring connection to this land, its waters, and its rich cultural heritage, and honour their wisdom, traditions, and ongoing stewardship of this land. So there's going to be a lot of information today, but the main goal is to help you better understand the difference between palliative care and end-of-life care. And I hope that by knowing a little more, when you're inevitably faced with end-of-life decisions, you can ask the right questions to help you and your loved ones live better to the very end. So we'll look at how advanced care planning and advanced care directives can be useful to protect you and your preferences if you lose the ability to communicate at any stage. And I'll show you where you can find some resources as a carer or someone with a life-limiting illness. And finally, we'll talk about death and bereavement and just touch on some of the things that are good to know. So what is palliative care? Some people think it's just for people with cancer or for someone in the last weeks or days of life, but that's actually not true. And people might feel afraid to accept palliative care because they think it will shorten their life or that it will mean that they have given up, as that picture shows. So while it is devastating to hear that your family member or a friend is considering referral to palliative care services, you should know that being referred to palliative care is not in itself a prognosis. So some people do receive palliative care for a few weeks or months, but an increasing number of people receive it over a number of years. Palliative care doesn't try to end life sooner, and it doesn't try to prolong life expectancy. And it's important to know that you can still continue treatment like chemotherapy while also accepting palliative care. But generally what it does is it represents a change in focus from trying to find a cure to living with an illness and managing symptoms in order to achieve the best possible quality of life. And quality of life is a term that can mean different things to different people, but it might include being comfortable and pain-free, being able to socialise and spend time with loved ones, being as independent as possible, or not feeling like a burden on others. But most importantly, accepting palliative care will not make you die sooner, and it is not giving up. The decision about when to contact a palliative care service rests with the person who is unwell, their GP or their medical specialist. And some people may benefit from receiving palliative care services as soon as they're diagnosed with a life-limiting illness. Others might find it comforting just to know that just connecting with the service, knowing that they're there, and that they'll be available when they're required. So we're going to be talking a lot about life-limiting illness. This is a non-exhaustive list of what that can mean, but a life-limiting illness is an illness that will, like a symptom of that illness, will cause death. So, as Stephen mentioned, palliative care shouldn't just be management of physical symptoms. The palliative care team supporting you could consist of a social worker for grief and bereavement support, a palliative care volunteer who may provide social support or help write a biography or just stop in for a cuppa now and then. Other care you can be offered could include medical treatment, relief of pain and other symptoms, access to resources like equipment that's needed for palliative care at home, nursing care, links to other services to help like home help and financial support, support for emotional, social and spiritual concerns, and referrals to respite services. So people providing palliative care recognise that every person has different physical, emotional, practical and spiritual needs, and that a holistic and interdisciplinary approach is best. So it's important that you or the person you're caring for discuss what services and supports are needed and when and how they're delivered. So there's often a misconception that palliative care can only be provided in a hospice setting, but it can actually be delivered in a range of settings, including outpatient clinics, by community nursing teams, consultation teams in facilities and hospitals, and specialist palliative care units. And the services provided will vary, but with most you will require a referral from your GP. So the best thing to do is call your local palliative care service to find out if you need a GP referral, And the specialist palliative care teams liaise with GPs and primary health care teams to provide advice and treatment based on the needs of the patient, their carers, and family. So when asked where they would prefer to die, most people will say they want to die at home. Home is what's familiar and comforting. It's really important, though, to understand that this option often requires significant planning and coordination, whether it's to source equipment or medication or for a carer to prepare and feel comfortable with their role. So I can't emphasize enough how important early conversations and referrals are to make sure that you have as many options as possible at this time. As I said before, the best place to start is by calling your local palliative care service. So on our website, Palliative Care New South Wales has a service directory that you can search using your postcode. And we also have a phone line that can connect you to an expert who can assist you with questions you might have. That phone number's there. And also make sure you're discussing options with your GP or specialist who can recommend services that they've connected with. So there are a lot of resources available online, and I know we'll be sharing these after the webinar. So don't feel like you need to write down all the tiny little websites, but it may feel overwhelming, and I would encourage you to take your time to understand your options and discuss what's important to you with those around you. CareSearch is a great website that has excellent resources and information for patients and carers. And on our website, we have a variety of resources and links, including our palliative caring booklet. And if you contact us, we can also send hard copies of this, as well as advanced care directive booklets, which leads us to advanced care planning. So it's important to acknowledge that a life-limiting illness may remove your capacity to make decisions about important matters in the final months or days of life. So advanced care planning is the process of discussing and documenting future healthcare wishes, values, and priorities. And it lets doctors, friends, and family know and understand what you as a person with a life-limiting illness wants should you become so unwell that you cannot speak for yourself. So you really need to begin these discussions and planning during the early stages of an illness, or better still, before. And it's important that you record these preferences while you still have the legal capacity to make decisions. In New South Wales, an advanced care directive is a written statement completed by you that records your health and treatment goals of care. So there is no set format. You can download a form from the New South Wales Department of Health, or we can post you the booklet, but completing these documents is the best way to make your preferences known about the type of treatment you want, if you're unable to participate in decisions, and to make sure that your family and health professionals respect these preferences. And after creating your documents, you should share copies with your substitute decision maker, family, friends, carers, doctors, and you can also upload them onto My Health Record. So I really encourage you to start thinking about what matters most to you now. And remember that advanced care planning is an ongoing conversation. So it shouldn't just happen one time and then never spoken about again, because values and goals will change, and what you consider acceptable outcomes might change. So you need to update your plan. Palliative Care Australia has some excellent resources for starting to think about your preferences. These booklets are downloadable. And again, they're designed to be, you can use them with health or aged care staff, family or friends. They can really help older people work out what would be right for them. And if you're really sick or at the end of life, rather than waiting for a crisis to occur, you can have these conversations early. The resources can be used to help talk about you, your health, and what you might want at the end of your life. And this gives you an idea of some of the things that you'd be thinking about while completing your advanced care plan. So it's important to understand yourself and your priorities before you can share them with those that will be caring for you. So I recommend really spending some time reflecting and pondering these questions and discussing them openly with those that you're close to, considering yourself, your life, your healthcare, and choices. So I hope I've explained the broad role of palliative care and how it can be provided over the entire course of an illness, sometimes for years. End-of-life care is a part of palliative care. It's often thought to be for people closer to the end of their life, but the timeframes can be really difficult to predict, and some people might only receive end-of-life care in their last weeks or days. Others could for much longer. So, like the overall palliative care approach, end-of-life care aims to help you live as comfortably as possible in the time you have left. And it can involve managing physical symptoms, helping with everyday tasks like washing or dressing, giving you emotional support, talking about your needs and wishes, including anything your family and friends need to know, and getting practical support with things like making a will or financial support. So the settings for end-of-life care are the same as we talked about before, whether it's in your home or aged care facility, a hospice or palliative care unit. Again, the best thing to do is have a plan, and even have a plan A and a plan B in case there's a medical emergency or something doesn't work out the way you thought it would. So it's important to know that palliative care and end-of-life care are free to access in New South Wales. So whether you're in your home or a hospice or palliative care unit. However, it's not possible for healthcare workers to be with you 24 hours a day. So you do need to consider who can support you if you choose to die at home. And having said that, there are fee-paying services that can provide this kind of care. So it's important to ask up front if there'll be any cost involved if you are looking into those. As a carer, there can be a lot to manage at the end of life, providing personal care like bathing and toileting, to mouth care and grooming, meal preparation, medication management. It's really important to ask for help from your palliative care service when you need it, whether it's for respite care or other support before it gets too much. Respite care can be provided in home or residential aged care, and there's a lot of community-based programs as well. So if you're caring for someone at home, the other thing to be aware of is you may experience mixed emotions as death approaches. You may be angry that this is happening, scared about what lies ahead, sad at the loss of someone you care for, and maybe relieved that soon their suffering will be over. The process might leave you thinking about your own life and mortality, and you might feel like you just want it all over and done with. So most people in this situation have times when they feel like this, and it's a really understandable reaction, but it's important, as Stephen mentioned earlier, to talk so you don't feel guilty about these thoughts and to understand them better. These responses are all normal and to be expected in a stressful situation. A lot of palliative care services have volunteers that can provide emotional support to carers who may not have friends and family to talk to about these feelings as well. So that's always a good option for support. So lastly, it's really important that people know when someone dies at home and it's an expected death, you don't have to do anything immediately. You don't need to call the police or an ambulance. Their body can stay at home to allow time for family and friends to say goodbye. You can also talk to the funeral director if you would like the person to remain at home for an extended period of time. The palliative care team can also support you in this. And a doctor, a paramedic, and some nurses can attend to confirm the death and organise a death certificate. So it's important to know that as a carer, you can take your time and process what's happened. Thinking about grief, you need to be able to express your grief, remembering that there is no right or wrong way to do this. And you may need support during this time from family, friends, or a religious figure, or a professional bereavement counsellor. A social worker might also be able to help guide and support you with practical tasks and questions after death, and they would be part of the palliative care team. So the palliative care doesn't end when someone dies. There's often grief and bereavement support for the family and carers afterwards as well. And it's a common myth that people get over grief. The reality is you'll always grieve a loved one, but the pain will lessen over time. And there may still be things that trigger your grief months or years later, and this response is totally normal. It's also important to take care of yourself. and others at this time, with self-care, as well as respecting that grieving friends and family may need support from you, but they may also need space, and everyone will be working things out in their own way. So I realise that is a lot of information to take in, but I hope I've answered some of the questions that you might have had about palliative care and end-of-life care, and how you can best support loved ones and have the best quality of life possible right up to the very end. Thank you very much. Stop sharing my screen.
Thank you so much for that. That was great. And I think you may have answered much of what Mary Prince has asked in the Q&A, but we'll see if Mary wants to come back to us on that when she's heard what Melissa has to say as well. So, no, that was great. It was so comprehensive, and what a great resource. So, Melissa, you're up next. The Violet Initiative helps people navigate the last stage of life, and they provide content, tools, resources, support programs for people right across the country. Violet has helped over 15,000 people and trained over 1,500 employees in a range of settings across aged care, home care, financial services, insurance, and funeral providers. What would we do without funeral providers? Melissa's personal experience gives her first-hand insight into the world of death and dying, while her deep experience developing brands and businesses with purpose keeps the Violet Initiative on track as a national social enterprise. So thank you, Melissa.
Thank you, Stephen. Good morning to everyone out there. It's a shame we can't all see each other's faces in these formats, but thank you for joining us. And I think we're all very aware that these are not the easiest topics to lean into on a Thursday morning, but I hope we can bring you useful information and support, and really all be part of the effort to try and normalise this work so that we can do a much better job of learning to talk and plan and care for each other. Thank you, COTA, for the invitation. Delighted to be here. And Megan, that was fantastic. So much covered in such a short time. So I'm going to talk maybe for 15 or 20 minutes with everybody. I've got a couple of slides and a video to take you through. Let me just screen. Hopefully everybody can see that. And I just wanted to start by acknowledging that I'm dialing in from Gundungurra lands this morning in the Southern Highlands. So fantastic to have everybody together. A little bit of, I guess, context and background on Violet. I think some of these sentiments have been already expressed so well by Stephen and by Megan, but really what we're talking about here is a life stage. You know, and we've been so good acknowledging other life stages and learning how to talk about them and how to organise services and supports around them. But the last stage of life, you know, the last 12 months or so of a person's life, we really don't do such a good job of. It remains taboo. It's not really well acknowledged, and much harder for us to talk about and plan for. So the work of Violet is not just about the end of life in terms of the last weeks, days or hours, but it's very much encouraging us as a society to think about this as a life stage and to think about the things that we need to do to talk and plan for that life stage, really so that we can make the most of the time we have in that life stage, because of course time becomes, you know, the most precious thing that there is. I'm leading this work because I went through it. My first husband, a wonderful man, Mauro, had a very aggressive and very sudden cancer diagnosis about 10 years ago now. We had very small children and a typically busy life for a young family. Took us all very much by surprise. And as I'm sure you could all imagine, going through something like that is never going to be an easy thing. But after his death, I reflected a lot on the things that should have been much, much better. we weren't able to talk about what was happening to him or to our families. We weren't able to talk about that as a couple or with his family or my family or even with his healthcare team. So we avoided those very important conversations. And he spent so much time in hospital in the last 6 months of his life, having treatments and surgeries that I think perhaps, he might have chosen not to have. He might have chosen to have spent more precious quality time at home with his family if we could have been helped to really understand and accept where his illness was at and to make the decisions that would have been better for him and for our family circumstances. So after his death, it really encouraged me to really focus my work on bringing more attention to this life stage and setting up a national support model to help people as they go through it. Because I think, sadly, so often we tend to do too little, too late. And that's commonly all experiences through the last stage of life and the end of life, whether that's an elderly, frail person who's reaching, the the natural end of a very well-lived life, or potentially someone younger who might be dealing with a chronic or life-limiting or terminal illness. So really, we're looking to support people through all of those types of circumstances right across the country. And Violet wants to become a really trusted, recognised organisation and brand in a way that we think about Lifeline or Beyond Blue, a place to turn to help people make sense of this life stage and to be able to access the right services and supports as they go through it. It's an organisation with a really long history. In fact, about 25 years this organisation has been doing different versions of this work under a number of different names. And really what it used to do was train volunteer mentors in the community, and they would go and work with with families in homes as they were caring for a loved one at the end of life. And I got involved quite a few years ago, about 4 or 5 years ago, and really could see that something really important was being done here, but it needed to be really taken to the community with a lot more scale and accessibility. So we've now built a platform, and we have a national network of volunteer Violet guides, and we have a whole range of online resources and tools and content that are available for everybody. They're free and they're available 24/7. So as Stephen said, as we've been building this model over the last couple of years, we've had a lot of people come through and access our support. We've been measuring the impact of that work, which I'll take you through. So there's been about 15,000 people that have come through now. And we've also been working with a lot of businesses, because it's been really interesting to learn how much different providers and businesses want to participate. They want to know how to support their customers and their employees and the families of both of those groups more through this life stage. So we've been doing work with healthcare and aged care and home care providers, but also the banks, the insurers, the super funds, the funeral providers. They intersect with this work every day, and they want to do more to help. I'm just going to jump out of the screen share now and share a little video with you. It only goes for about 2 minutes, and then I'll return. Of course, the quicker you try to do these things, the slower you end up being.
I learned about the Violet Initiative accessing some of Ian's super fund through his super representative, and she was very kind. She had empathy on what we were going through, and she recommended to me to ring Violet. Talking to a Violet guide really did change my life. It was so needed at that time in my life, because things were moving very quickly, and I think I'd given so much to everyone else that I hadn't thought of me. I was able to see the reality of where I was at and what I had left to do, because the end of Ian's life was coming. So it was a reality check-in. And to have that at that time, I felt was what I needed to make me a better carer for Ian. So it was a relief for me. The Violet resources were absolutely educational, informative, and done in taste. I shared the video watching it with my son Thomas, and we did get a better understanding of things. We knew what to look out for, and we felt better equipped for the stages that we had to go through. Death and dying is not a often spoken about subject, and we all like to hide away from it. But now there's help out there. There's places you can contact Violet. You can educate yourself on your friend or whoever you've got dear to you that is going through this stage of their life, and make your life better and be able to help someone else. Reach out to Violet and learn, get some knowledge, better prepare yourself for the journey that you're going to go on and provide for your loved one, so that you can honour their wishes and get that strength to carry everything out that you need to do.
Going to return to the slides. I hope that was a short but helpful little introduction to some of the work that we're doing. And again, I think, Stephen, you did a great job of setting the scene for some of the change that's needed around this work. It is a global problem, right? There are majority of Western countries are looking at ageing populations. We had the intergenerational report released by the Treasurer a week ago. This is a very real and changing shape of our countries and our societies, and we need to do a lot better than we're doing today. We've been really interested in the work that the Lancet Commission has been doing in this area, and they released an important report about new models of care that are needed as well last year. We've been doing this work over the last couple of years with a really remarkable group of leading clinicians, both here in Australia and overseas. Some of those faces may be familiar to you. They are not only leading clinicians and academics, but they are authors, many of them both here and overseas. And we've been so grateful for all of the time and huge hours and knowledge that they've brought to the development of Violet's model and the development of our support programs and our impact framework over the last 2 or 3 years. All of that's on our website if you'd like any other detail. So as I said, we see this work as really a very complementary resource to sit right alongside the wonderful work of palliative care that Megan spoke to, but also a really important part of a better customer service experience with a lot of the businesses whose work intersects with this particular life stage, so that we can connect to the people that need this help and get them the information and the resources when they need it, and help them to have those honest conversations and create those plans so that we can really reduce a lot of the regretful outcomes that happen when the planning and the conversations don't happen, and help people manage complex family dynamics that can sometimes exacerbate those situations as well. This is, again, the work that we've been doing with some of our clinical committee members, but it's important sometimes to look at why things don't go well, what's behind some of those behaviours and symptoms where things really do end up in a regretful set of outcomes. And we know that people struggle to talk about this topic, but we also know that there are complex and culturally diverse behavioural barriers. It's a really highly charged emotional time. There's a lot of fear, anxiety and grief that people are dealing with, and just so commonly they're feeling overwhelmed and unprepared. And really, when we look at the tens of thousands of people that have visited our site, the most common thing they ask us is for help because they don't know where to start. That's the most common need state. We just don't know where to start. We don't know what we don't know. How do we even step into this life stage and start to think about all the things we need to plan for and talk about? The second thing is that things don't go to plan, or sadly there is no plan. And certainly part of that is an advanced care plan, as Megan was talking about, but it's also just thinking about care needs and all the other dimensions of this particular life stage. The numbers are pretty low in terms of the range of people in the country that do that and do that well and communicate it efficiently. And again, that's where we really want to help lift those numbers. And I think Stephen and Megan both pointed to often the unwanted, unnecessary and unplanned time that can be spent in hospital. And that's so commonly a result of rushed decision-making or poor communication. We see typically people having about 4 episodes, up to 33 days spent in hospital in the last 12 months of life. And a large part of that is often what we call non-beneficial, and it's representative of a hospital episode where perhaps that person could have been at home or could have remained in an aged care setting or their home-like setting, and not being in the hospital setting. The place of death is an important metric. It's not the only metric, but it is an important one. And what's happening today is that 1 in 2 people are dying in hospital, and that's our least preferred place to die. It's also a very expensive place for people to die. It's not meeting what people need, and it's costing the health system enormous amounts of money. So we're very keen to find ways that we can help people have the experience that they want to have, as well as create more efficiencies within aged and healthcare settings. Excuse me, just a second. Very unfortunate to get a tickle in your throat when you're presenting on a webinar, so excuse me for all that coughing. There's a couple of different ways that we provide our support today. Again, this is all free and nationally accessible. There is self-led online support where you can visit violet.org.au and tell us a little bit about the circumstances you're in. And we'll be able to provide you with curated content that really meets the needs that you're likely to be facing given your circumstances and the circumstances of the person that you may be caring for. The other option is to book in to talk to a Violet guide. So we've been running guided support programs for the last few years now. They're roughly 3 lots of about an hour's session. We deliver those over the phone or through video conferencing, whatever is most appropriate for you and for what you're after. But they're delivered by, oh, I'm sorry. They're delivered by our Violet Guides, and that's a national network of volunteers that we've been building over the last few years who all have a lived experience of caring for someone. They're very tightly selected and recruited and trained and supported by us as they deliver these programs to people nationally. Interestingly, a lot of our Violet Guides have come from a health or a palliative care or an aged care background. But a lot of the guides are also people in the community that have been through this and want to use their own experience to help others improve what they're going through. So it's been a very well received service. I've got some impact figures which I'll take you through later in the deck. Thought it was nice to just share a little bit of the way that these guided sessions are managed. It uses an evidence-based conversation framework that we adapted from the NHS in the UK. So it's very rigorous in the way that it's managed in terms of safety and support for people. And it really, at the heart of it, goes to 3 anchoring questions: understanding the role of a caregiver and the impact and agency that that person has, understanding what matters most to the person that you're caring for around their own wishes and preferences for the last stage of life, and starting to think about what to expect, to be prepared for the experience of the last stage of life, and in particular to be prepared for the conversations and the decisions that are a natural part of that life stage, so that if things do happen, the 2 a.m. crisis moment is often a pretty inevitable part of that life stage. We are prepared for those moments and we know how to act in accordance with the person's wishes. So again, this is all freely available on our website if you'd like more information, and there's a lot more detail around how to access guided support programs and what others have said in terms of their testimonials, their experiences. We've been measuring the experience of the 15,000 people that have come through over the last couple of years, and it's a piece of work that we're really proud to share with you, that a very high proportion of people feel much better equipped to engage in those end-of-life conversations as a result of our support. They know what matters most to the person who's dying. They've been able to have those conversations and create those plans and know much, much more about the wishes and preferences. And really importantly, and Megan, I think, this links very nicely to a lot of the work that you presented, because we all have the same North Star. We all recognise how important palliative care is, and early referrals are best for everybody. But we also recognise that often palliative care is a bit misunderstood or a bit misinterpreted in the community. And what we're able to show is that 1 in 2 people that come through our support are accessing palliative care much, much earlier, which is wonderful for everybody. There's a couple of testimonials there, and as I said, there's a lot more of those on the website if you're interested. And last but not least, as we grow this out, we're really expanding our work with a lot of partners, a lot of businesses and brands, and there are a lot of other smaller organisations that we're working with. But I just thought I'd give you a bit of a sample of some of the bigger, more known brands that you may well be familiar with, that are really thinking today about how they support their customers, their customers' families and their employee communities as they go through this life stage, or as they care for loved ones who are in the last stage of life. So it's been really heartening for us to build out that work and become part of their infrastructure and their customer service models. And I'll just give you an example of Westpac, who we've been working with for the last few years. But every one of us is connected to a bank, aren't we? And within Westpac alone, about 30,000 customers die each year. So it's a very important and clear channel for us in terms of reaching the people that need what we're providing. So I did have a question slide, which I'll skip over because I understand that we're doing that collectively at the end, but that brings me to the end of my slide deck. And of course, my cough has stopped now. I'm sorry for that, that little interruption in the middle of my talk where I had one of those persistent and tickly coughs. Thank you for the opportunity to take you through the work.
Thank you. And no worries about your cough. I often hear my patients apologizing for various, whatever they've got, whatever ails them. And I say, no, you shouldn't apologize. You shouldn't say sorry for it. And particularly around grieving and tears and death and dying, people often apologize. And I say to them, well, we don't apologize when we're at the checkout at Woolworths for the potatoes that they're selling us. So we're all, whether we're neighbours, friends, family, moving to a world where we don't have to say sorry for our feelings or coughs would be a very nice one, wouldn't it? So thank you, very much, Melissa. That was, I think, Megan's presentation and yours just complemented each other beautifully. So there have been a few questions. Mary Prince, maybe you'd like to just put into the chat. She was wondering, how do I get palliative care into the home? And I'm not sure if she feels that, Mary, that's been answered. But yes, it's easy to do that, and I'll just say as a practitioner that I find that palliative care is called upon almost always, far too late in the process. Palliative care in the Liverpool model, which was made many years ago, was that you should wonder whether your patient is going to die in the next 5 years and start the conversation, start the power of attorneys and the enduring guardianships and the advanced care wishes. Now that's been reduced in common practice to 1 year, probably because there aren't enough people in palliative care to provide that information. But there are, because we've got the Palliative Care New South Wales, Palliative Care Australia, Melissa, your program. So we really should be asking these questions if we have them much earlier in the process, preferably while we're well. Barack Obama and family said when he became president that he wanted everyone to make an advanced care plan, no matter what age they were, and certainly to start talking about it. I know our 6-year-old grandchild starts to talk about death, and I think some families find that a difficult conversation and may say, oh, you don't need to worry about that. But I would be very much pick up on that opportunity and talk about it. There is no age at which it's inappropriate to talk about the lifespan. I'm sure, Violet, you've got access to the libraries on books for children around death. So
yeah, there's a lot of. I think there's a good couple of hundred articles on the platform, Stephen, and the way we've set it up is, if you put in some information about your circumstances, what you're looking for, it will serve you up the most relevant content.
Yeah, absolutely.
You're so right about the the need to just broaden this. I mean, the death rate is pretty stubborn at 100%, isn't it? That's not going to change anytime soon. And while I think we need to work in closest proximity to the problem, the more we can do over time around the social change piece to normalise the conversations all the way through life, the better.
Absolutely. Well, everyone calls death and dying different things. First Nations people often will call it passing, because they have a very strong relationship from the earth to the land and then back to the earth. And I think we've got so much to learn from the knowledge of First Nations people when we make social choices about how we will live, die and grieve, because they've been doing compassion and compassionate communities and 80,000 years, and it's helped them thrive in life and death. So it's always worth remembering that. Anne Ring has popped something in the Q&A, which perhaps I'll read out to everyone. I don't know whether people are monitoring that. So Anne says that she's an 81-year-old health sociologist, and she's got an important chapter in her recently published book for older people. So we'll put that on the resources. What matters when we grow older. Other questions? Will anyone be talking about power of attorney, and can it be taken away from Janine? Megan, do you want to answer that?
Yeah, look, power of attorney is different to the person responsible and the substitution decision maker. So that's really more something you need to talk to a lawyer about, and about taking care of someone's estate and finances and all that sort of thing. So that's not really what we're focusing on. That's a different specialty, not mine.
Yep. Well,
Yeah, but I think there are a lot of free services too. There's legal
Yeah.
aid, there's
Yep.
some great online, because I think, you know, we all know that turning to a lawyer can be an expensive process sometimes.
That's true.
So I would encourage people to look for some of those more freely available services to get those detailed questions answered.
Yeah.
COTA did have legal services for just this, but unfortunately it was the funding for it was not kept going. But I think it's a very important service. And
Yeah.
sometimes if you have an aged care package, support with a social worker to help you work that out could be part of your package. So speak to your package provider if you've got an aged care package, because there's always money in that for this whole range of things that you might need. And one of them is advice on power of attorney, enduring guardianship, writing your will, and putting all those things aside, because very often, and I've had patients who, and I wonder what are they worried about, and then eventually they say, look, you know, I want to change my will, you can tell they're worried about something, and sometimes it's something that can be done so simply.
That's right. Rosemary's popped in the Seniors' Rights
Yep.
Service,
That's
which
good.
is great.
Yeah.
And also OPAN, the Older Persons Advocacy Network, is a fantastic resource. I would encourage everybody to have a look at OPAN's site and support services.
Yeah, you've got it. That's right. And I think when we're talking about palliative care, that word palliative, I can see over in the years to come, there's a lot of discussion about whether palliative puts people off. They think it's just the last little spell and we'll get the doctors in to fix it. And I think there's discussion in high places about whether that's the best way to put it.
Yeah. Yeah, I think very necessary discussion. I look forward to seeing where that goes.
Juliana, you asked about it was Julie Bailey asked, is Violet Initiative accepted in retirement villages?
Absolutely. Yeah. We're partnering with some of the bigger providers now, so hopefully you'll see that expand over time. But I just want to emphasize that anybody can access our services and platform for free. So just have a look at violet.org.au.
And Juliana, you said you're more interested in the dying at home than the cost that hospital might have, and I think that's a very important question, because health systems don't seem to be able to move cost share. So if the good work of Megan and Melissa means that someone stays out of hospital, it really should be that money is saved and put into home care. The Royal Commission they wanted it last year, but it's been moved to this year. They want more people to age at home. And I think we're going to see more funding put into that. But unfortunately, funding is one of those issues. There is a person, Peter Kenyon, who speaks in this area because he supports communities. And he says that if you're relying on funding, you're barking up the wrong tree. The initiative and the sustainability has to come from the community itself, your family, your friends, your neighbors, and setting up. And that's where I think the future lies. And that's why we try and promote compassionate communities. And I have to acknowledge here that COTA New South Wales has peer leaders, and they're like community leaders, and they are working so hard. They're wonderful people to help connect people. And we all like our emails, our posts to go viral. Well, let's hope that the idea of helping each other, kindness, will go viral as well, that people will help each other in the community. Now let's look for more questions here. There's one, Martin Mulcair. There seems to be a common expectation that one battles a serious illness. How can we make palliative care more welcome without appearing to be giving up? a little bit to what I was saying. Palliative care's got that reputation of being just at the end. But actually,
And I think it's important for people to know it can happen alongside other treatments, and it's not that final stage. So I guess that's just getting that message out there constantly that palliative care can be introduced. Some people can have it for their whole life. If you're diagnosed with cystic fibrosis, for example. So I think it's just changing that and educating people about it. But yeah, it's not giving up. I hate hearing that word.
No, that's right. I mean, it's a spectrum, isn't it? Because as we age and bits start to fall off, as I say to people, chronic disease, that's what it's called in the medical world, the diabetes, the kidneys, the hearts. But again, if you share that with people and you make social choices in this latter part of your life, and loneliness and isolation are really our worst enemies. And we did a webinar. Look up in the COTA series for the excellent webinar that was done, I think either the last month or two, about loneliness and its effect on health. And it's along the spectrum. Most the loneliest group is the younger people, 15 to 25. But we know that up to a third of older people are lonely and isolated. And so some of the work we're doing when we're offering help is obviously all of the things that you've shared with us, but the larger picture of how are we going to encourage people to connect. And that's, again, a very strong part of the COTA New South Wales strategy. Community connectors, our community leaders, our peer leaders, to get people connecting. Hasn't that been your experience, Melissa and Megan, that connection is so important?
Yeah, absolutely.
Yeah.
I sometimes say we don't need so much a hotline as a hot drink.
Yeah. And that's the role often of volunteers in palliative care teams. To provide that social support, whether it's dropping in for a cup of tea or just a conversation. So I think, the role of volunteers in providing support in the community is huge to combat that as well.
And, it's been really interesting to look at the times of day that we know people are trying to reach out to get that support. So we're seeing a lot of demand after 8 o'clock at night. And you can understand that, can't you, in such an overwhelming time where people may just find the space, find the time, take a breath, and then be wanting to reach out for that help. So 8 till 11 p.m. is often a really peak time for our service. It's important to provide that.
If some of you aren't chat literate, the Senior Rights Service has got a free legal advice, so that's important that people know. Jane Mears says, I wished I'd listened to this webinar 5 years ago. So in a sense, if you have friends, neighbours, family, and your feelings there, Jane, are universal. People just haven't talked about death and dying and grieving and getting old enough. So share this webinar with your friends, because they probably, there's a very good chance, wouldn't you say, from your research, Megan and Melissa, that too many people, we'll just say we won't put a number to it or percentage to it, but far too many people are not having conversations about this.
Yeah, absolutely.
Yeah.
Oh, there we go. Jane's on it. And good caring relationships with trusted people will do. so I encourage everyone to do that, because we'd like this to go viral. That's how social change occurs. It's not by what we tell people to do. It's what people do between each other. Have a dinner, host a dinner. Very effective. There are lots of resources if you have difficulty starting the conversation. And I'll look out the link and send it to everyone later. There's packs of cards, believe it or not.
Yeah, the PCA cards,
Yeah,
the
you've got
discussion
those,
starters.
Yeah,
We do,
yeah.
and they're great. And they're just
Can you put that link in?
I can.
There are cards that are, I think, First Nations appropriate.
Yep, there's ones for rural and regional areas, older people
Right.
and First Nations. So and they're brilliant. You just sort of flick through and think, oh, I hadn't thought about thinking about that.
Absolutely. When I do a presentation at a conference, sometimes a workshop, every table's got the cards, and they have a great time with it. But have a dinner, sponsor the conversation. It's great. Call it we're going to have a card night. That'll surprise people when they see what the cards are. But
but you've got them there by then, so they can't leave.
Yes, you've got them there. Exactly. You've got them in. I actually find when people start to talk about it, it's such a great relief.
Yeah.
Just like Jane was saying. So that's good. Now let me see. Q&As, there's many more come in, I think. So let's see what we've got here. My Q&A cursor's not working very well. Sounds like palliative care is not always end-of-life care. That's absolutely right. I'm interested in the WA initiative where the community connectors people who'd lived experience of end-of-life losing a loved one. The answer to that is no, not necessarily. They just maybe had a dinner with friends and saw that volunteers were being searched out, but you're anonymous, so we can't. We'll put links to the Bunbury Compassionate City initiative, sending out a reminder that most of the heavy lifting of caring for someone who's dying is done by family, friends, and neighbours. We need to care for those who are caring for the caring, and that's absolutely right. Only less than 5% of a person's day is contact with formal care. That's the doctor, nurse practitioner, support worker, social worker, pharmacist. 95% is provided by what we call informal care. And that can be anyone. I've helped look after people at end of life where I'd say probably 95% is given by a beloved pet. Anyone's, people to mow the lawn, people to provide food, someone with a large washing machine who says, look, I don't want to do all the hands-on stuff, but you leave a nice, like the nappy service used to be, you leave a nice big heavy plastic bag on your doorstep every night with all the sheets and the washing. I'll take it away and I'll have it back cleaned and dried the next day. Now that makes a huge difference. I've spoken to high-level people in the hospitals and they wonder why so many people coming into hospital. And in my experience, very often it is because they cannot keep up with the laundry. It's so simple. People know about this who've done it. And so there's always a job for anyone to do. Now let's have a look. There's one thing missing for me when my husband passed away. Feel free to take over the Q&A. One thing missing for me when my husband passed away, no one called to check on myself. We live hundreds of kilometers away from family, so it was a particularly difficult time for me until I got myself together and started to look around for something to do. Absolutely, absolutely. And we know that the most effective people in grieving are family and friends. The statistics list them as far outrunning the professionals. So having that cup of tea is so important. Any views on or contributions to voluntary assisted dying from your organisations? Melissa, Megan.
Yes, I expected this one.
I'm surprised it hadn't come earlier.
I am too, actually. Look, I guess the point I would like to make is that palliative care is not a pathway to voluntary assisted dying. So then it's not the same thing. Going into palliative care does not lead to that. Voluntary assisted dying will have their own navigators and a whole system that you will have to engage in if that's something you're looking into. So I just really want to make it clear that, palliative care should always be offered to someone facing a life-limiting illness, first and foremost.
Yeah, we as an organisation remain quite neutral on assisted dying. It's can be a somewhat polarising topic in the community. I think the effort is really on helping people well in advance of a conversation around assisted dying. You know, as Stephen and Megan and I have been making the point, if we can talk about these, the plans, the wishes, the preferences for this life stage earlier, that's benefit all round. And for some members of the community, that will end in a conversation around assisted dying for those that's right for. But I think there's so much broader benefit for us to think about alongside of that.
Starting that conversation early is just so key to
the key. It's so
to the outcome that you want, whatever it is.
Yeah. There's quite a few little role play videos that we've developed just to help, because sometimes just seeing these conversations enacted is a useful way to build some confidence to open them. So I've done a couple of those, as have our guides, and again that's on our website if anybody would like to have a look at them.
So that's right. And in most of the states where voluntary assisted dying is now legal, and it's coming to New South Wales in a month or two, the numbers have not been huge. But what I think it stimulated is the conversation. And so, there's been two great purposes there. And I suppose linked to that, and perhaps our coming up to our last question, let me just scroll down. What is the difference between palliative care and the hospital service? Would one of you like to answer that? I could certainly have a go, but why don't I hand over to you?
Yeah, I think, do they mean receiving palliative care in hospital?
Yep.
Or, yeah. So palliative care is an approach to the end of life. So it's not about being in a hospital, I guess. Whereas you could have end-of-life care in a hospital service, or you could be admitted through an emergency department if you had a medical emergency. But palliative care is really more about that approach to planning and, the social supports and those sorts of things around reaching end of life, and even after that for the family, for grief and bereavement support as well. I hope that kind of answers it.
Yep. No, palliative care works everywhere.
Yeah.
And my experience is at the moment, palliative care nurses and specialists are absolutely wonderful. I mean, not many specialists visit people at home. Geriatricians do sometimes, but palliative care specialists always visit people at home. And when they visit people in hospital, the stay in hospital completely transforms. It becomes a completely different experience for the family because of the great skills of palliative care workers. So there we go. That's some more links coming in, and we'll obviously send all of those out to people. So I think we're, I'll just check there's no more. Apologies if I've missed any of your questions. No, I think there's a couple of comments about an excellent presentation. Talking to the person who's died often leads to tears. Well, if the good Lord had not sent us down with tear ducts, let's use them. They're very important. They're an important part of grieving. in that respect, I do want to just repeat those two numbers, and maybe we'll put them up again on the chat. Melissa's number 1-800-VIOLET, and the lifeline 131114. Because conversations like this should bring up some complex, difficult, but sometimes very clearing emotions. So that brings us to the end of today's webinar. We're out of time. So much to talk about. I can probably go on talking under wet cement about this topic. Thank you, Megan and Melissa. And as I said before when we started, thank you, Karen, for managing the webinar. Thank you, Joan, for all your work. I know you're passionate about this. We be an email going out to you shortly with extra information, resources, the YouTube channel, so that you can share. These webinars are a regular feature of what we do here at COTA New South Wales. So stay tuned to hear about our next webinar in September. And thank you so much for joining us. I hope you've enjoyed the discussion and learnt some new information.